Welcome. Today we'll be discussing endocrinology, specifically cancers and hypoglycemia. My name is Max Barnett, and I'm excited to share my first video with you, so sit back and enjoy. All right, so let's start with a case presentation, and we'll learn to distinguish true hypoglycemia from factitious hypoglycemia. So let's start with a nurse. She's a 39-year-old female, and she's brought into the emergency department with a hypoglycemic episode. She's resuscitated, and she makes a full recovery. Strangely, the registrar notes this is not her first presentation for such an occurrence, and when she regains consciousness, she is adamant she has an insulinoma. So I suggest pausing here, trying to dissect this case, get together the important points, and we'll go through it together. All right, so here's the important points I found from this case scenario. So she's a nurse, she has medical knowledge and access to medications, she has confirmed hypoglycemia. We note this is her third presentation, something strange is going on, and she doesn't appear distressed when she has this presentation. She's almost happy for the diagnosis, and she's insisting this is an insulinoma. Again, a bit strange and requires further assessment. All right, so let's consider what differential diagnoses could be causing this recurrent symptomatic and biochemical hypoglycemia. So first things first, does she have diabetes? Maybe she's taking too much of her medications. Could this just be after a large meal, postprandial excess release of insulin? Maybe she has a true insulinoma. Maybe she has Munchausen's. Because she's a nurse, she has access to insulin. Now let's consider maybe it's dumping syndrome. She had a previous bypass surgery. Maybe this is a failure of either the liver, the kidneys, or the adrenal glands. Maybe it's Addison's disease. Again, let's consider maybe she has insulin autoimmune syndrome. This is more common in Japanese patients. Maybe she has excess alcohol abuse, which is inhibiting gluconeogenesis, acidoblastosis, or maybe poisoning, where someone else is giving her insulin. Now, this is a very important slide. Let's start on the left-hand side where we see Whipple's triad. The presence of all three are required. So fasting hypoglycemia, as we can see, symptoms of hypoglycemia, and reversal with correcting glucose levels. All three mean that a patient with hypoglycemia requires further assessment. They may have an insulinoma, but it does not distinguish the cause, and that's very important to understand. Now let's look at the right-hand side. So as we recall, insulin is made in the beta cells of the islets of Langerhans of the pancreas. It's initially created as proinsulin, which is then cleaved into insulin and C-peptide. C-peptide means our own body is producing insulin, and it's very important to consider. So when someone's injecting insulin, such as the nurse in the case study, that's suppressing our own endogenous production, and therefore there will be low C-peptide levels. So that can distinguish between our own insulin and exogenous insulin. So to distinguish an insulinoma from other causes of hypoglycemia, we perform the 72-hour fasting test. And this test is performed over 3 days or until a patient has symptomatic and biochemical hypoglycemia, levels of which are less than 40. In an insulinoma, there will also be increased levels of insulin and increased C-peptide levels. Remember, as we said, if you inject insulin, the levels would be low. So it is important to withhold sulfonylureas prior and during this test because this will lead to endogenous stimulation of insulin release, and it could have high insulin and C-peptide levels. So if there's concern, we can measure the sulfonylurea metabolites within the urine. So let's look at the biochemical evaluation now. So if we turn our eyes to the right side of the chart where it says exogenous insulin, and we take the example of the nurse, she's administering insulin, therefore her insulin levels are naturally going to be high. Of course, the glucose will be low, but when you administer insulin, it tells the body's pancreas to go to sleep, and therefore her C-peptide levels are likely to be low. If we compare this to an insulinoma, of course, high levels of insulin, low glucose, but it's the body's own insulin, and therefore C-peptide levels will be high. If you turn your attention to the middle of the chart, you see sulfonylurea, and you can see that it looks quite similar to an insulinoma, and therefore this is why they must be discontinued to avoid interference. A further caveat I'd like you to be aware of is that C-peptide is renally excreted, and therefore in renal failure, interpret the levels with caution. When you administer anything forward into your body, antibodies may develop, and therefore if we look at the case study with the nurse, she very well may have insulin antibodies. A further thing to be aware of is that insulin is an anabolic hormone, and therefore whether it's exogenous administration or an insulinoma, patients may note weight gain. As you can see, there's further ways to distinguish an insulinoma in red written on the screen, but let's turn our attention to the bottom where it says beta-hydroxybutyrate. This is a ketone, and typically when you fast, the levels increase and insulin is typically suppressed. However, in an insulinoma, high insulin suppresses the beta-hydroxybutyrate and therefore levels will be low. If we look at glucagon stimulation, typically again in fasting, Glucagon breaks down glycogen from the liver and increases our glucose levels in the serum. However, with an insulinoma, this prevents glucagon breakdown and the levels are naturally preserved. So when we give glucagon, it breaks down the stored glycogen and leads to a rapid increase in glucose levels within the blood. So how do we actually treat an insulinoma? So first we need to identify it. So we start with non-invasive methods, traditional imaging, or we move on to invasive methods written on the screen. It's important to know an octreoscan scan is not helpful in an insulinoma, and this is probably the only neuroendocrine tumor where it is not, with a sensitivity of no more than 50%, as it does not have the somatostatin subtype 2 receptors located on it. Surgery is the most important and principal treatment for an insulinoma, which can lead to a cure. However, not all patients are candidates, in which case they're given diazoxide. This decreases the insulin release and increases glucose levels concurrently, but patients must be warned of edema as a consequence. Also, 10% of insulinomas are part of multiple endocrine neoplasia type 1, and therefore they need to be screened and their family members. All right, so now let's move on to something else. So what if they are observed and are not taking insulin or sulfonylureas? What if they fulfill Whipple's triad? What if they have suppressed rather than increased insulin levels? And what if when you look at the pancreas, it's normal and you see this on their CT scan? So pause the video and have a think about the diagnosis. And the diagnosis is, drumroll, Doege-Potter Syndrome, something most people are unlikely to ever have heard of. This is a very rare condition with less than 100 cases confirmed worldwide, but it's an important cause of hypoinsulinemic hypoglycemia. These are solitary fibrous tumors, typically benign mesenchymal tumors of the visceral pleura of the lungs. And it's only called Doege-Potter syndrome in less than 5% of cases when the prohormone of insulin-like growth factor 2 is released. This prohormone leads to massive stimulation of the insulin receptors, and therefore insulin is suppressed. So there is hypoinsulinemic hypoglycemia. It's important to note more commonly, in up to 20% of solitary fibrous tumors, hyaluronic acid may be released, leading to acromegaloid features known as Pierre-Marie Bamberger syndrome. However, for the purpose of this talk, we're going to focus on Doege-Potter syndrome. So what do we know about Doege-Potter syndrome? So we've already said at least a hypoinsulinemic hypoglycemia, therefore patients will be positive for Whipple's triad. As I said, Whipple's triad just makes patients categorize that they need further assessment. It does not help determine which tumor they have. Moreover, IGF-2 and the prohormone, as I said, bind to insulin receptors as hypoglycemia. What's also important to note is growth hormone is classically suppressed, so there'll be low levels of growth hormone. In nearly half of all cases, the hypoglycemic episodes precede the diagnosis of the tumor. So it's important to be aware of the many manifestations hypoglycemia can present as. This could be very severe, such as a comatose, or more subtle, such as personality changes, or it could even be from the mass effect of the tumor itself. So there's no gender preponderance. It's equal in males and females, and it's most common between the 6 and 7 decades of life. So in the following diagram, we see the effects of insulin-like growth factor 2. As we've said, although insulin levels are decreased, it's because IGF-2 is binding to its receptors. There's also concurrent decrease in the release of growth hormone and glucagon, with increased glucose uptake into the muscles, all of which lead to hypoglycemia. So how do we manage and how do we diagnose Doege-Potter syndrome? So most of the tumors are benign and can therefore be resected. However, we also need to consider the acute treatment of the hypoglycemia with either glucagon or dextrose. We can't measure the prohormone of IGF-2, but we can measure IGF-2 itself. So during a hypoglycemic episode, we measure the ratio of IGF-2 to IGF-1. Typically, when it's greater than 10 to 1, this suggests Doege-Potter syndrome. Normal and high levels of IGF-2 help with the diagnosis, but low levels do not exclude the condition, and that's very important. We also need to be aware that when stimulating the insulin receptors, this can lead to internalization of potassium, and hence nearly half of all patients will have hypokalemia. For those of you who love the TV show House MD, it's one of my favorite shows. Please watch the episode on the screen. It gives a great overview of Doege-Potter syndrome. We have now reached the end of this video. Thank you for sitting through, and I hope you learned something. Remember to subscribe to us on YouTube, watch all of our newly released videos. We are Elite Medical Revision. You can also contact us on Gmail, elitemedicalrevision@gmail.com, and look out for our books on Amazon. Thank you and have a great day.